This video is brought to you by Global Men's Wellness, your 24/7 AI health expert. No copays, waiting rooms, or awkward conversations. Just real answers whenever you need them. Visit globalmenswellness.com to try it free and get your own on-demand concierge-level wellness expert today. Welcome to the Global Men's Wellness. I'm Dr. Judson Brandeis, and I'm so glad you're here. There are few true urologic emergencies, but the one we are going to discuss today is perhaps the most time-sensitive and misunderstood. It is a condition that, if not treated within hours, can lead to the permanent loss of sexual function and a lifetime of consequences for a man's physical and mental well-being. This isn't about a disease that develops over years. It's a crisis that unfolds over minutes and hours. The battle for a positive outcome is often won or lost based on a single decision: the decision to overcome embarrassment and seek immediate medical help. Today, we will explore this critical condition, a persistent, painful erection known as priapism, and the modern, decisive framework urologists use to save not just tissue, but a fundamental part of a man's identity. Priapism is defined as a persistent penile erection that continues for hours beyond, or is entirely unrelated to, sexual stimulation. For the purposes of clinical management, we are talking about erections lasting more than 4 hours. But it's crucial to understand that not all priapism is the same. The most important distinction a doctor must make is between two very different types. The first and most urgent is acute ischemic priapism. Think of this as a compartment syndrome of the penis. It's a low-flow state where blood gets trapped in the erection chambers, the corpora cavernosa, and cannot escape. This trapped blood quickly loses oxygen, becomes acidic, and begins to cause severe pain and cell death. This is a true medical emergency. The second type is non-ischemic priapism, a high-flow state often caused by trauma that creates an abnormal connection, or fistula, between an artery and the corporal body. In this case, the blood is flowing freely and remains oxygenated. The erection is not fully rigid, and it is typically painless. Non-ischemic priapism is not an emergency. The biology behind these two conditions dictates the entire approach to treatment. In ischemic priapism, the failure of the normal detumescence, or relaxation mechanism, leads to a closed-off system where smooth muscle tissue begins to die from a lack of oxygen, leading to fibrosis, or scarring, and permanent erectile dysfunction. The mechanism for diagnosing this is swift and definitive. After a history and physical exam, a clinician performs a corporal blood gas test. A small needle is used to draw blood from the corpus cavernosum. If the blood is dark, hypoxic, and acidic, with a pH less than 7.25, the diagnosis of ischemic priapism is confirmed. In non-ischemic priapism, that same blood sample would be bright red and have the same oxygen and pH levels as normal arterial blood. If the diagnosis remains uncertain, a penile duplex Doppler ultrasound can be used to visualize the blood flow, or lack thereof, in the cavernosal arteries. The framework for managing priapism is laid out in the 2022 AUA and Sexual Medicine Society of North America guideline, which was developed after a comprehensive review of thousands of medical studies. This is not based on theory, but on the best available evidence. What's new about this modern approach is its emphasis on a diversified, individualized pathway instead of a rigid, one-size-fits-all algorithm. The evidence is clear that for ischemic priapism, time is tissue. Conservative therapies like oral medications, cold compresses, or exercise are unlikely to be successful and should not delay definitive treatment. The first line, evidence-based treatment, is corporal aspiration, to remove the trapped deoxygenated blood, and the intracavernosal injection of a vasoconstrictor called phenylephrine to help open the outflow channels. Awareness of priapism as a true emergency is critically low, often due to the rarity of the condition and the significant stigma associated with it, which can cause men to delay seeking care for many hours. This delay is the single greatest threat to a good outcome. Patients must understand that an ischemic erection lasting more than 4 hours is a critical event. The guideline strongly emphasizes that clinicians should counsel all patients with persistent ischemic priapism, that there is a significant chance of developing erectile dysfunction. If the event has lasted longer than 36 hours, the likelihood of recovering natural erectile function is very low, regardless of the treatment performed. This is a hard conversation, but an essential one for setting realistic expectations. The patient experience for acute ischemic priapism is an emergency room visit that must be met with urgent action. After the diagnosis is confirmed with a corporal blood gas, the penis is numbed with a local anesthetic block. The first intervention involves placing a needle into the corpora to aspirate the thick, dark blood, often followed by irrigation with saline and injections of phenylephrine every few minutes. Throughout this, the patient's blood pressure and heart rate must be monitored. If this fails to resolve the erection after about an hour, the next step is surgical. The patient is taken to the operating room for a distal shunt procedure, where a small connection is created between the tip of the corpora and the glands to allow the trapped blood to escape. Personalized urologic care is central to the modern management of priapism. The guideline moves away from a single, mandatory pathway and allows for clinical judgment based on the specific scenario. For a man who presents with an ischemic event that has already lasted over 36 hours, the corporal smooth muscle is likely no longer viable. In this case, after a frank discussion, the patient and clinician may decide to bypass shunting procedures altogether and move toward the early placement of a penile prosthesis. This approach provides immediate relief from the painful priapism and offers a definitive treatment for the resulting erectile dysfunction, while potentially preserving more penile length than if the implant were placed months later into a fibrosed penis. The effectiveness of these treatments is entirely dependent on timing. If treated within the first few hours, intracavernosal phenylephrine and aspiration can be highly successful. Distal shunts are also effective at achieving detumescence, but the risk of subsequent ED remains high, especially with longer durations of priapism. For non-ischemic priapism, observation is the first step, but for persistent cases, selective embolization successfully resolves the issue in about 85% of patients. For refractory ischemic priapism, early penile prosthesis placement has been shown to have high rates of patient satisfaction and avoids the complications of severe corporal fibrosis. The future of priapism management hinges on improving our understanding of its fundamental causes and on developing better preventative strategies. This is especially true for patients with sickle cell disease who suffer from recurrent stuttering episodes. More research is needed to identify the precise timeline of irreversible corporal damage, which would allow us to better counsel patients and make more confident decisions about when to move to an immediate penile implant. Additionally, developing therapies that can control thrombosis within the corpora could play a huge role in preventing shunt failure and minimizing tissue damage. Ultimately, prospective comparative studies are needed to refine our surgical techniques and optimize patient outcomes. I do this work because managing priapism is a clear and urgent mission to preserve a vital aspect of a man's health and identity. There is no room for hesitation. The better way, championed by these modern guidelines, is one of rapid diagnosis, decisive and evidence-based action, and honest shared decision-making. It's about recognizing when to fight, to save natural function, and recognizing when the battle has shifted to preserving the organ and providing a definitive prosthetic solution. It's about empowering men to overcome stigma, seek help immediately, and ensuring they are met with a clinical strategy that gives them the very best chance at a healthy and sexually functional future. Take control of your health anytime, anywhere. Visit globalmenswellness.com and start your free trial today. Get expert-level answers in seconds, not weeks, without the cost, the wait, or the awkward conversations. Real support on your terms. Visit globalmenswellness.com now.